nursing homes are kind of the emphasis of the day, but we're going to talk about hospitals as well, as they tangentially connect. This workforce is a shambles across the state. We're not taking up the DSPs and the ARM discussion we had last time, but that is unresolved and unchanged as well. We are just facing, in my mind, just grave peril about these matters, and the goal of this hearing, as the others, was to call attention to it and try to talk about it as a legislative committee in a collaborative way. I think that's the way out of this. So anyway, there'll be ample chances for people to talk. We do have, I kept thinking we'd have a smaller agenda, but it just, there are these things related to all that. Just, it actually is a focused agenda for as long as it is. I think we'll spend the most of our time talking about nursing homes. And then we'll mention hospitals, and thanks to Mayo and Alina for chiming in on that. I didn't ask anybody else. I just thought we'd have a little bit of an idea, and then we'll hear from the hospital associations. And then we'll go into some other matters that are important, but probably won't be as lengthy. So with that, I posed some questions to the departments, Department of Health and Department of Human Services. Did we decide, Tom, that the departments are going to go first?
I believe yes. MDH
Okay.
is going to lead off.
Anyway, so I asked questions like how many nursing homes have closed? How many are at risk of closing? How many are in receivership? How many staff have separated over the recent Biden mandate? And I was curious about where they were spaced around. And how many residents have moved to no location or at risk of needing to move, and how many have nowhere to go? Those are pretty grisly questions to be asking, and with serious times. And so I hope the answer is all is well. So who wants to be the first one to proclaim that? Ms. Rydrick, do you want to go first, and then we'll let Dan pick up whatever. Good morning.
Good morning, Mr. Chair and members of the committee. My name is Diane Rydrick, and I'm the acting assistant commissioner, for the Health Systems Bureau at MDH. And pleased to be back here with your committee. And I'm sorry to hear that this is the 6th when you didn't plan to have any, but COVID continues to not cooperate, I think, on that. So do you want me to just go through the questions that you sent in advance?
Well, whatever you're prepared to say. Yeah, that's a good start. And then if there's something else you want to comment, then I don't know if Mr. Pollock's going to fill in different gaps, but that's the question. Then we have some testimony. So if you want to just go through those, I don't know, whatever level, and then we have 3 testifiers as well. So.
Okay. So yes, I'm happy to do that. And I will just note, starting out, we agree staffing, as we've talked about before, staffing concerns are very real in long-term care, and not just in nursing homes. They're very real and very serious in assisted living facilities, in group homes, in other congregate settings, and not just in long-term care either. As you noted, you'll be speaking to, it's a problem in hospitals as well, and those issues really intersect. Staffing issues on the long-term care side have an impact on hospitals and vice versa. And so
Sure.
I'm pleased that you're thinking of it as a holistic issue. And I know I've said this before, but I'll say it again. These are longstanding challenges for the industry. You know that, your members know that. The vaccine mandate is one factor that has, I think, made things more challenging for some facilities in areas of the state, especially where vaccination rates for healthcare workers are low. But what we're seeing is, even now that the mandate is on pause, which I think this group is all aware of, a federal judge paused the CMS mandate and put a temporary injunction in place that is nationwide. We're still seeing, I think that may have given some facilities a little bit of time to take a breath and, plan for what's going to happen if it does get reinstated. But it is a serious issue, mandate or no. And at least this time, when we're here before you in the committee, we can talk about some really serious steps that the administration is taking to address those staffing concerns too. And I know that
perfect.
To talk about National Guard. So I will speak just briefly to the questions that you sent. You asked how many nursing homes have closed. So every year, around 5 nursing homes close for different reasons. So we look back at the last few years, and it really varies between maybe 3 and 7. There's usually a handful. We are on the same pace for this year right now. There were 3 in the early spring, February through April, which were not directly related to staffing. And then I think I've mentioned when I was here prior, we did get a notification about 2 to 3 months ago from a facility in Minneota, which was closing at the end of the year. And again, as is often the case, it reflects longstanding challenges that the facility has had, and they finally got to the point where they decided that was the best step for them. So there are no additional nursing home closures that have happened in the interim. You asked whether some are at risk. I do think that there are some that are at risk. We know from conversations that we have had with nursing homes, we know through the information we're getting through the National Guard request process that there are facilities that are thinking about it. I can't quantify it because there's not an obligation to tell us when they start to think about that as an option that they might want to pursue. And a lot of nursing homes aren't going to want to tell their regulator that that's a path that they're going down at this point. So we do know that some are at risk through our surveys, through our National Guard work, through connections that we have through the long-term care associations, through the ombudsman's office, and others. There are some. I would say what we hear in those conversations, though, when they happen, is that most of these facilities are doing everything they can to avoid that. They're working, if they're part of a corporate chain, they're working with corporate to see if there are financial relief or incentives or other things that they can do. They're sometimes talking with sister facilities in the community to see if they can consolidate residents or staff. They might change their licensure. We are definitely seeing some or hearing of some that have reduced their census. They've stopped taking admissions, or they might consider once a resident leaves a bed that they might put that bed on layaway and just not fill it in the future and kind of put it aside for a while. So they're taking different steps to kind of manage with the staffing that they have. So I might pause there. You had a question about receivership, but maybe I'll pause before I take that one.
No, that's fine. Just keep flying through. I think that why don't you fly through and then Dan will fly through, and then we may come back to some of these. There's anyway, at least I heard from one member that he's got places closing. So we'll get to that, I'm sure. But I just want to know what your answers are, and then we're not going to debate them now. You just tell me your answers.
All right.
We'll hear somebody else's answers, and then we'll figure out. So keep going. Thanks.
All right. You also asked how many nursing homes are in receivership. There is just one, which we've spoken of before, and that's Twin City Gardens. We are not aware of any others that are moving to that. And I just want to emphasize again, a receivership is a very different thing than a closure. It is a legal process, usually a long time coming because of issues, financial challenges. Things have to get really dire for a receivership to happen. And it is essentially MDH taking over based on a judge's order as the owner essentially of the facility and hiring a managing agent and moving into that role with the facility. And it doesn't always end in closure. Not all facilities that have gone through receivership close. So it is a very different thing, and there's still just the one. You asked how many staff have separated over the CMS mandate and wanted to know that by facility and by county. We do not have that information. You'd have to ask the facilities for it. We don't track how many people may have left for any reason, much less the mandate. Okay. And then finally, how many residents have moved to a new location or are at risk of needing to move? So there's not a requirement to tell us every time that moves or is at risk to move. So we don't have that one.
Well, good. Well, I appreciate what you don't know. So you can't tell me what you don't know.
I can't tell you what.
But I know somebody who can. Mr. Pollock can tell me every answer. Do you want to add any of that, Dan, or is there?
Good morning, Mr. Chair. I appreciate the opportunity to speak, but I agree with everything that Assistant Commissioner Rydrick has said. I'm primarily here to add content and information about what DHS has brought to the crisis that you described, both funding and resources for long-term care providers.
We'll get into that later, I think.
Yeah, I think we're going to come back to that later. I just think the more we can consider safety for residents, respect and respite needs of workers, and stability of the long-term care system, and the sustainability of all of these things.
Yeah, that's fine. Thanks. Ms. Thurlow, welcome to the committee. You've been here before. I think you were, reasonably, what do you call it? Understandably concerned I'm waiting to hear that everything's fine. So is all fine now? Are we good to go? Ms. Thurlow, welcome.
Mr. Chair, members of the committee, good morning. Thank you for the invitation. For the record, my name is Carrie Thurlow. I'm the Senior Vice President of Advocacy for Leading Age Minnesota, but also here on behalf of the Long-Term Care Imperative. I'll be brief and say that we do not feel that all is well, but Mr. Chair, if you don't mind, I might defer to my colleague, Nicole Matson, who can give an overview of the data that the Imperative has been collecting since our last hearing.
Oh, let's do that then. That'd be great. Ms. Matson, welcome back to the committee.
Thank you, Mr. Chair, and good morning, members. My name is Nicole Matson with Care Providers of Minnesota, here today with the Long-Term Care Imperative. Really appreciate the opportunity to speak with you today. So we wanted to give you an update regarding some of the data points. Since we last spoke, we've resurveyed members regarding census and occupancy and found, not surprisingly, that the crisis is deepening in long-term care. So we had previously indicated from a survey that we had done earlier this fall that about 70% of providers were limiting census. However, our most recent data indicate that over 76% of members statewide are limiting census due to staffing constraints. However, this number is significantly higher in rural communities where upwards of 90% of providers are limiting admissions. And while we didn't specifically resurvey regarding open positions, we have confirmation that the negative trends persist. We were experiencing on average 2,000 more staff exits than hires per month, and those numbers are substantiated by providers who are holding admissions. It just means that our overall job vacancy rate continues to grow.
Do you know what the vacancy number is overall?
The total vacancy rate statewide? No, but
I mean, how many is it, like 10,000 or?
It was 23,000, so we know that that's certainly the low number. If we've experienced 2,000 more per month, you know, it's grown. So
and is it like 40 something thousand staff you have altogether? So you're short a third?
We were short 20%. And we know that that number is higher. We just haven't resurveyed specifically for open positions.
All right, thank you. Keep going.
Yep, so providers' inability to attract new staff in and the burnout and exhaustion experienced by current staff, which accelerates turnover, have hampered any efforts to return to quote unquote normal operations. Overall, nursing home occupancy declined dramatically as a result of the pandemic, and we've seen limited recovery in 2021. At present, our data indicate record low average occupancy rates of around 78% statewide. And again, some rural communities experience even lower occupancy rates. We've seen these limitations to census directly impact the healthcare continuum with backups in hospitals, and we're starting to hear stories about lack of access from seniors and their families who are unable to obtain care when and where they need it. But we also know that these challenges affect the overall viability of the entire industry. It's a perfect storm of increased costs, increased turnover, increased number of open positions, and low census, which have created a recipe for disaster. On average, Minnesota nursing facilities have experienced lost revenue of over $1 million from the start of the pandemic through June 2021. So we're certainly appreciative of all the emergency temporary measures announced by the administration related to workforce and look forward to working with them on additional interventions. But we also recognize that there must be permanent solutions if we need to stabilize the long-term care industry and ensure that we can provide for the needs of our seniors today and into the future. And I know we have some providers that can speak better to the depths of the crisis and provide more context, so I'll turn it over to them.
And maybe if it's Ms. Peterson, but can you comment on the current state of the, what do you call it, the CMS mandate, I guess we'll call it that. Don't want to personalize this to the president, but you know, it was his. But so that was a big cliff that everybody's worried about. And then suddenly it was on hold, I think just last week. So I mean, you go from the big crisis to now uncertainty, but how is that working based upon what you know?
Well,
what's the status? How's that affecting things?
Yeah, sure. I mean, as Assistant Commissioner Rydrick pointed out, I mean, it's on hold, which, you know, was welcome news for many providers that, you know, had really limited options. What are the implications of it? I think we really need to see in the next coming months how the mandate is going to be rolled out so that we would know. It was our intention to resurvey members regarding open vacant positions once there was more known factors with the vaccine mandate. Whether that'll be in January, we don't know.
Sure. Do you know how many people, and you may have to look this up, a year ago, how many people were leaving the industry a month? Can you figure that out and let me know? So
Yes,
let's talk to
we
Ms.
sure can.
Peterson. Do you know offhand?
Jim,
Know that it's grown, but I can get you the specific number.
Senator
Chair
Hoffman
Abler.
knows the answer to the question.
I wish I did, Senator Abler. Thank you, and I'm so glad
Welcome.
you gave a shout out to our President Biden. He did it in such a great. I like how you did that. That was.
It's a very nice office, by the way,
Thank you so much. It's in Ramtucky, Minnesota.
in District 35.
Yes,
Fortunate, man.
yes,
People wish
yes.
they there.
We just might be combined together one of these days. So, hey, I have that is an inside one. Senator Abler, the 23,000, I just want to get some clarification. Is that all positions within our umbrella of nursing home care, or are those just direct staff? And if it's not, what do we know about the direct staff numbers? Everything from, you know, an aide to a nurse. Are those
Hey,
numbers?
Ms. Matson, you probably know that. Do you know that answer?
Chair Abler, Senator Hoffman. So the 23,000 was all positions. Of that, about 15,000 were those direct caregivers. I guess I would have to look up the nursing specific positions.
No,
But a significant portion is those direct caregivers.
And that goes in line also, Senator Abler, Mr. Chair. Thank you, Ms. Matson. That also goes, we just got a notice of the HCBS home health care and folks that those numbers are just absolutely growing. And so I wanted to see if we knew what the very direct impact to the care, daily care. And if it's 15,000, that's a lot. So thank you for those numbers.
All right. Thanks and welcome. Ms. Peterson, do you want to tell us what's going on in your world? Thanks for coming in.
Hi, are you talking to me?
I am, yeah, welcome. This is your time to tell us what readings from the, so we've heard from people who work in offices. Now we're going to talk to you who's actually out there in the front lines. So
Great.
that's your job here. So a couple minutes about that would be great.
Okay, great. Thank you. I'm Dr. Peterson DeVries with St. Francis Health Services of Morris. I'm also an adult geriatric nurse practitioner. And so we really represent, we have 13 nursing homes, 10 assisted living, and over 70 group homes. And so we are primarily in rural areas. And certainly what Nicole talked about is certainly affecting us tremendously in the area. We really are looking at decreasing in census all over. We've put beds on layaway. We have some of our care centers are at 60% to 70% occupancy. Many of them are still under 80%. And all of it really is directed towards due to staffing. We have, like I said, 13 long-term care facilities, and it's a good week when we can take in 20 admissions in all of them. And so that really is, we know that isn't necessarily a good service to our communities. However, really understanding that we don't always have the staff to take care of them is really a problem. We have done all kinds of things to try to be creative in building our workforce. We have looked at people that have left our organization. Are they willing to come back? We have looked at trying to recruit from different industries in a way where we do all of our onboarding and training in-house. We pay for CNA training, and we pay for their time to take CNA training. And we've just done a lot of those types of things and continue to be in the staffing. I'll give you an estimate on the overtime and our bonus. Right now in our overall payroll, we are sitting at about 15% of bonuses and overtime. And that's primarily that 15%, even though it's not broken out, is primarily due to the nursing departments. And so it's probably higher if we broke out just the nursing department's payroll. Yeah, go ahead.
Keep going. Yeah, no, you're doing good.
So we also have seen this decline in full-time employees. We have had turnover in our administrators and our DONs. We have had DON turnover, 6 of them out of our 13 and 5 out of our 13 administrators over the last few months. We think there's multiple factors to that with COVID. There was some definite, the regulatory pieces of that. There's also this real adversarial relationship with the Department of Health that's almost a "we got you" kind of attitude. It's been really evident to us a little bit more. We had an administrator join us a few months ago from North Dakota, and he has just been in awe about how adversarial our relationships are with our surveyors. And it's not all teams, but there's certainly that. So we have thought that the National Guard has been really helpful and encouraged our organization administrators to do that. But there's this fear, first of all, that they're admitting that they need help and that they can't take care of people, right? And then they don't want to report it because there's fear that maybe the health department will then come in, and now we've opened ourselves up to more problems.
Wow, that's amazing to me.
Yeah.
That's not okay with me, by the way. And maybe Senator Housley and others, we should dig in more. I mean, we can talk about it a little bit now, but that's not helpful.
Not helpful at all.
I don't think Ms. Rydrick knows that's going on from the way I judge her body language and her tone. But someplace down the food chain, someone thinks that's the way to do it. And we have never thought that was the way. I've been in office 22 years. We've discussed this topic for all those 22 years about surveys being reasonable or not. Anyway, so keep going.
So we do believe that in some ways, when you have a director of nursing or an administrator under that type of pressure, they're getting out of the industry. And that's really scary also, because if you don't have key leadership positions too, it's really tough to manage care centers.
Yeah. So can you tell me, I don't know if you've come to every one of our 6 hearings. You should have, because they're just that amazing. They're really good TV, better than many movies. Just the interest, anyway, maybe they're not, but we've had testimony along the way from a couple of your colleagues and some staff about how the impact of the mandates on the CMS mandate, which was due 2 days ago or something. Right. How that was affecting people's approach. And a bunch of people are leaving over fear of that. Has it's on a stay right now. Have some people wanted to wait till the last minute praying something might happen and they haven't quit? And there's some people just on the edge if it comes back, and have some people already quit just knowing it's coming and didn't wait? Can you comment about that?
Yeah, I do. So I wouldn't have exact numbers, but we did have some people, as the mandate came out, turn in their notice just saying it's just not worth it.
Yeah.
And we do also have some people that were waiting for the last minute to make their decision. Yeah. In a few of our buildings, it's maybe 6 or 7 people, but often it's in the nursing department. So we know that that would hit those places, especially in northern Minnesota. We have several up on the Iron Range. And so we know up there they were concerned about the mandate. But it has helped that it's on a stay. However, we feel it's given us more time to get exemptions to help our staff, or not help them, but recommend that if they're going to get an exemption, to get that in order for us. And so we've somewhat continued the process. And we believe vaccination is the right thing, but definitely we can't lose staff.
Right. And so can you comment about the exemptions? The medical ones hopefully are straightforward and they're all being allowed for. Can you comment about the religious ones? And I don't want you to give away any of your secrets. But in general, for me to talk to you, just if you can give me a generic answer across your industry, that'd probably be better for you. And so what percentage have been approved? Do you have any idea? Just a ballpark. I'm not going to hold you to it, but you're as close to the front line as we've got. I know you talked to colleagues. So if you have 100 people requesting a religious exemption, do 100 get it? Do half get it?
I would say that most of us in the industry are approving religious exemptions, with the understanding that it may not be our place to make that judgment on whether or not it's a religious belief or not.
Well, thank you. Well, I don't know. Maybe I should say it. I just don't want to have too much anecdotes. There was some discussion that the MDH was suggesting a less liberal policy, and some discussions about there might be more surveys if you do too many. Have you heard any of that, or is that just totally a false statement?
No, what we have really heard from MDH is that they weren't really going to be looking at the exemptions. They were going to make sure that we had the process in place.
Oh, that's what I wanted to hear. And so, but that came to me from a source that I thought was kind of reliable. So I hope that's not true. So I hope that they would just, my view is that, we're a pluralistic country. We're a nation under God, says on our dollars, but you don't have to believe in God. You can have any faith you particularly choose to in this country. That's kind of a hallmark of America. And so I don't know how you get some God bless some 24-year-old person in HR deciding that your faith is good enough and the next one's not, but that is happening in some places we'll talk about later. So any of the other testifiers, Ms. Rydrick, did you want to respond to anything here? Or anybody else want to comment before we take questions from members?
Yeah, Mr. Chair and members, I would like to respond to one of the comments, and it's related to facilities being worried about applying for National Guard assistance because they're worried about a regulatory response. And that's something I have heard anecdotally that there might be some facilities that are worried about that. And we have tried to do everything we can to let people know that that is not the case. This is a place and a way where a facility can let us know that they need help. It is separate from our regulatory function. And in fact, if a facility has a National Guard team that goes on site, we are making sure that we would only be going on site in that facility if there was a complaint that was triaged as an immediate jeopardy. So an extremely serious complaint that we would be go in to investigate because of the immediate jeopardy concern. We would not be going into a facility because they have raised their hand and said that they need help. We want facilities to let us know that they need help. That is what the National Guard is there to do, is to provide that support so they can continue to provide safe care to their residents. So if there are ways that we can work to communicate that even more clearly, that does not trigger a regulatory response, I'm open to ways that we can do that.
Thanks. And can you comment on this adversarial relationship? Have you heard about that in your travels around your department that Ms. Peterson, Dr. Peterson was mentioning?
Mr. Chair, I think we'd be happy to follow up with Dr. Peterson on that. We try to always have a collaborative relationship with the facilities that we regulate. We have responsibilities under state and federal law. We're not always going to agree with a facility on, the correct remedy for a situation, but we never want to have an adversarial relationship. So if there is that, and if there are situations where we'd love to talk about that.
And I appreciate, I think that's the right answer to the question. I think it's come out more than once. And so I think it's more adversarial than you might think in the home office. And I know what your policy is, but then as it gets trickled down through various, however your interest, what your chain of command looks like. But I would personally find that to be something I would be intolerant of, especially in these times. We put it on our list of things with the Senate plan that I was part of with other members to mention that. It comes up all the time. And I think it's useful for you to notice Dr. Peterson's concern and reflecting her peers that if you ask for help, you're going to show it you're vulnerable. And then if you're already having a rocky relationship with your surveyor, then why would you put yourself at risk about that? And so that does not move us closer to a resolution, that moves us further. So I appreciate you taking that back to your folks and talking about it, because I don't think the governor intends it. I don't think the commissioner or you intend that to be the case. But then the reality is sometimes not as pleasant as what you hope for. But then when people who don't intend that find out about the reality, they can actually, change something about it. So,
yeah, I appreciate that. Dr. Peterson, we would be happy to talk about this with you. People are under a lot of tension on all sides. The industry is exhausted. They're stressed. These are serious challenges. And I think that just makes everything a little bit more fraught too at the same time. It's difficult.
I do speak to a fair number of people like Dr. Peterson, and it just puts them over the edge. And it does affect people's desire to stay working there. They just can't take it anymore. They're trying so hard to serve somebody in the best way they can, and then there's some minor infraction that becomes the order of the day, and something a surprise, or somebody who's got kind of a wild hair going against somebody, and that's not helpful. So maybe I'm being a little more emphatic than I was earlier, but it just cannot be. And this is definitely a question of administration. It's nothing we can do to pass a law, if even you guys would sign it. But it is a matter of how you implement what everybody intends. And I think it's very solvable. And I think some private, candid conversations could go a long ways. And there may well be some truth in what I said with my question before. And so I would just appreciate you digging into that. And, one of the ways to remedy this is to stop the unnecessary pressure on these places. So thank you. Senator Housley.
And then Senator Mr. Chair. And to that point that you're on right now, what a question for the department is I'm hearing a lot of complaints about the adversarial relationship with the surveyors also. And I know you'll take it offline with Dr. Peterson, but there's so many providers that are watching this hearing right now that really want to know what steps is the department taking right now to address this, and where can these providers go to raise questions about these surveyors? They're really, really afraid of retaliation right now. And this is happening not just in Dr. Peterson's, but across the whole state. And when you have somebody come in from North Dakota to go, whoa, what's happening here? There's going to be too much for you to contact each provider to figure out what's going on. So what's the process that the department has in place right now that providers can raise questions about these surveyors, because there's a lot of fear happening in these facilities right now.
Did you want Ms. Rydrick to respond to that? Go ahead, please.
Yeah, Mr. Chair, Senator Housley, we are happy to talk to anyone who has concerns, and they can escalate it within the department. If there are concerns with the way that the regulatory process is working, if there's concerns with a surveyor specifically, or with our approach to how we survey facilities, they should come and talk to us and escalate that. I know that there are going to be times when that relationship is not going to be perfect. As I said, everyone is stressed. We are ensuring resident safety, and it's not always going to be a smooth process, but we really do work hard to make sure that it is collaborative and that we're working with a facility to figure out how to get them on the right track or on the right path. But there is always an ability to escalate that. I can say we get letters of praise from facilities and appreciation for the collaborative approach as much as we hear about problems. So I think it's a really mixed picture, but we really want people to let us know if there's a problem, and we will escalate it and we will talk about it. And if there's something that we should be doing differently, that we can do differently within our statutory responsibility to protect residents and our state and federal obligations, then we'll explore how we can do that.
Senator Housley.
Thank you, Mr. Chair, and thank you, Ms. Rydrick. I feel that the facilities are hesitant to go to MDH because they really do fear retaliation. And I don't know what we can do or what you can do to help alleviate that, or is it something we need to do at the legislature? They're just afraid. They're afraid to give you guys a call for fear of some backlash. So I don't know if you've heard that, or maybe we should have the providers anonymously voice that to you, because it really is happening out there.
And Senator Housley, I was just going to say kind of the same thing. Ms. Rydrick, I would never, if I was Dr. Peterson, I would never take something through the process. Because in the meantime, if the person truly is adversarial, they're going to get you. And their word is law. And the reports that go online on the websites, or here you had these infractions and people were in peril. So I think you need to think of a better way. And I think that MDH has I'm just thinking of this, Karin, but I think MDH has a responsibility to look at their surveyors and see what kind of things each person is finding. And maybe there just needs to be a survey excellence thing, and some people need to be let go if they're really far out of line reporting things that are truly petty. And maybe if the people that are getting letters of commendation should be the trainers, it seems to me, and that's the exemplar, and people that are deviating beyond, what kind of work they're doing, and the safety of the people. At the end, the safety of the client is the best. How many people really did come to harm, and what did you stop by some of the reports? So we can't spend much more time on this part, but I think Senator Housley, I think you're onto something. And Ms. Rydrick, if you could find some way to go back to the home office and talk to your oversight people, I've got to think there's a bell curve. There's probably some people that find too little, and who wouldn't want that person? But some people are digging too deeply, and they may have an attitude. And in these times, we just do not do that. So, Senator Housley, did you want to comment?
Yeah, thank you, Mr. Chair. I completely agree. I think if there were some sort of anonymous survey, which if you were out in the private sector, that's how it would be. But I think it would be really good feedback that the department could get if these providers knew that they were providing this survey information anonymously, so they wouldn't have to fear the retaliation. Just if maybe, Ms. Rydrick, you could look at something like that, just so they could unload all of what they are feeling without fear of retaliation. And that's it, Mr. Chair. And then I'll have another question for after Senator Hoffman. Thanks.
Yeah, Senator Hoffman.
Thank you, Mr. Chair. And I think this gets to that whole compliance versus technical assistance provisions, right? The department has to wear two hats. They have to be the technical assistance provider, which is the knowledge wonk to help you understand, what services, supports, whatever questions you have. And yet at the same time, they have to be a regulatory compliance person. And so, Senator Abler, I'm wondering if there isn't specific delineated language that says when somebody calls, or somebody does a surveyor, is there a technical assistance lineage piece here? Because I should never feel that if I'm going to call the department that they're going to go into a compliance hat right away, right? I mean, do you understand what I'm saying, Senator Abler? Because there's clearly a difference. And so I guess the question to Diane, because it almost sounds like Diane approaches it from a technical assistance. I need to help. We need to help, right? I mean, that's where they're, and yet at the same time, we know there's the compliance hat they have to wear, right? So, but does everybody have that same understanding, Ms. Rydrick, that you do between technical assistance and compliance? And if not, do we then need to do something as a legislature to say, here's the technical assistance provisions that need to be brought about, and do you want us to get that smithy on something, Senator Abler? But I think in all my years that there's always been a difference between the compliance hat and the technical assistance hat. And in this case, as a provider calling or surveying, it's time to provide that technical assistance.
Ms. Rydrick.
Yeah, Mr. Chair and Senator Hoffman, I think it's an important point, and it is a tough balance to strike sometimes. Our surveyors regulate. They are on the front lines, making sure that residents and making sure that they are carrying out their responsibilities under state and federal law. But we regularly get questions from facilities who are struggling with something and need help. And we do have people who are not out in the field as regulators who will take those calls and talk to them and talk through options with them. I would note too, a lot of times what we do here, and this kind of goes back to Senator Housley's comments about fear of retaliation or anonymous surveys, we We often work with the provider associations on that, or things will get filtered through the provider association. So someone will go to care providers or leading age, they'll come to us and raise an issue, we can advise. So we work through that relationship as well, because sometimes facilities feel more comfortable going through their provider association. And then we meet regularly with them and just kind of exchange information about what we're hearing and what are the options and ways that we can help. So that is another avenue, whether it's people raising concerns about our survey approach or about individual surveyors, we can raise it through that process. And that's just another avenue and a place where sometimes facilities feel more comfortable.
Ms. Rydrick, when a person, let's say Ms. Peterson was just expressing that she or some of her colleagues are nervous to get a hold of you, they might really not benefit from the National Guard thing, but they're like, oh no, this is just we're already having a bad deal going here. If like the helpline or whatever group that is, when they call to do, questions, do they keep track of that? Does that go on the record so the surveyor could see that this group asked for help? Or is that kept separate?
Mr. Chair, we are keeping that separate. We do let.
Good, that's the answer I wanted to hear. So then the surveyor would never know. No, at least that way that people, I think that the nursing homes would like to know that, right? Go ahead.
So, Mr. Chair, I would just say, as I noted before, though, if there is a National Guard team on site in a facility, we want to make sure that the surveyors do not go out to those sites during that time period, because a surveyor is going to be assessing what the staff, the regular staff of the facility are doing and how they're performing their. Now you've got this variable with a National Guard team in there. And
no,
so
I get that. But these are people that really should call for the National Guard, and they're afraid because they think that, Mr. Whomever is going to really kick the hammer down. Oh, you're a little light on that. I thought you were. Well, we're going to make sure that people know that. So, but there's a separation there which does not get sent off to the surveyor.
Yes, Mr. Chair, I just want to be as clear as I can. A separate function. The surveyors know when a team is on site so that they can not go there unless there's a complaint that is triaged.
I'm talking about people asking for help. Like maybe we should get a team.
Yeah.
Because we're having a hard time filling our complement of staff.
Mr. Chair, if a facility is having a staffing crisis and needs National Guard support, they should ask for it. If there are other ways to say more clearly that that's not going to trigger a surveyor coming out on site.
And that makes it, that's it. Mr. Chair.
That well. So, all right.
Mr. Chair.
Senator Hoffman.
So yeah, this answers the question. I mean, clearly the surveyor going on site is doing a compliance. That's a compliance activity, right? Diane is absolutely, there is that somewhere along the line, there's misinformation about, if I pick up the phone and I call Ms. Rydrick's office, I'm asking for technical assistance. I'm asking for help. That shouldn't trigger a compliance piece, right? That's that.
It sounds like it doesn't.
And it sounds like it doesn't. So
it's a good question to ask. This good discussion.
Yeah, no, thank you, Mr. Chair, for doing that. I'll let you go.
All right. Ramtucky. Anyway, Senator Housley.
Thanks so much, Mr. Chair. I had a question for Dr. Peterson. We'll give Ms. Rydrick a break.
She's ready for one.
Yeah. So I'm wondering, Dr. Peterson, how long can facilities sustain such a low occupancy before you're just not financially viable? Like how long? I know I'm guessing you're almost at the end, but how, like into the future, how much longer can you go?
I think so. The most current dollars that have come from the grant dollars and all of that are really going to help us cover some of our overtime and bonuses and retention and all that. But I think that is a concern that we look at almost on a daily basis. We have Zimbrota is we have one care center in Zimbrota. We compete with the Mayo. They had 143% turnover. They're paying nursing assistants $10 an hour bonus, and we're paying overtime, and we still can't fill shifts. Hopefully the National Guard is going to be able to help us there, but our census there is 25 this week out of 40, and we can't staff enough to to increase census. So those areas, and I don't think we're alone as an organization. I mean, that census issue is so problematic from a long-term basis that fortunately we have a company that we are drawing from in those smaller buildings. But it is a concern, and justifiably so. It is a serious concern for the sustainability long-term.
Senator Housley.
Thank you, Mr. Chair. That was my thoughts. Thank you.
All right. Well, then Dr. Peterson and then Senator Nelson. Do you have any idea how many people in Zumbrota left over this CMS mandate concern or otherwise like that?
That area is probably not as much over mandates. We did have a couple that were going to leave that we got exemption forms on this week.
Yeah.
But that
hasn't been part of that. Okay.
Yeah, it's more about the competitive wage. Mayo is in the same, looking for help too. And we just dropped. Sure. It's just tough. And we can't compete with those kind of wages.
Even for $10.
Even $10 an hour more a shift, we can't compete. So people will go and work there and maybe come to us in Zumbrota as a part-time casual, where they'll just pick up a shift when they're not working at the Mayo. But that doesn't help us sustain the care that we need.
Holy cow. Senator Nelson, you have an answer for us?
Thank you, Mr. Chair. No, I don't have an answer, but certainly this is not a new problem, but it's very concerning. The stability of our long-term care facilities is important to every one of us and to all of our districts. And my question has more to do with, earlier I know we had been concerned about long-term care facilities going into receivership. That was one of our last hearings, and I think that's still a concern. And the one thing that I would like to know, and I think might be beneficial for us, is to look at what has happened in the past as some of our long-term care facilities have gone into receivership. I remember one case in my district, and it was very concerning at the time to have the state, in a sense, the department take over that long-term care facility. Now, I don't have all the ins and outs about what transpired. I was there right at the beginning to help see what was happening with that concerning issue. But what I would say is, in hindsight now, I don't know how they made it work, but I can tell you that that long-term care facility is up and running, doing great, and has continued very good service. So I think perhaps, we hope we don't get into these receivership issues. I think trying to figure out a long-term sustainability model for our long-term care facilities is incumbent on all of us. But I think we might be able to learn some lessons from what happened in those unfortunate cases that went into receivership, but have emerged as financially sustainable long-term care models that are serving Minnesotans well. I don't know if there are others. I just know about the one that happened in my district. I think perhaps there could be some lessons we could learn from that.
And so maybe Ms. Rydrick could comment, but maybe Senator Housley, this is not to give you more work, but maybe come January, it's, we're kind of hitting the edge of this thing, and we're going to have to move on pretty soon. But these are all questions that are at the heart of long-term care policy, and not just in nursing homes. Nursing homes, in my opinion, were the flashpoint and the short-term crisis, which is why we're focusing on those today. Ms. Rydrick, do you want to comment, or then we'll go to Senator Wickland?
Thanks, Mr. Chair and Senator Nelson. I guess I would say we agree a receivership is not a situation we want to be in either. And it's something that is thankfully very, very rare. I think I mentioned at the outset, a receivership is very different than a closure. And of the handful of receiverships we've had in the last 15 years, there is that I'm aware of that did not end in closure. And I'm guessing that's the one that you're referring to. So it is not inevitable that a facility closes, but it's kind of a reboot opportunity for them. And in at least one case, it didn't end that way. But in others, they do, because it's, they're at a point of such serious physical plant deterioration, the amount of money needed to fix the deteriorating building, the financial arrears that they're in, sometimes it's insurmountable. But it's not a situation we ever want to be in either. But it's one we have to take sometimes to protect residents.
And I think we don't want to miss the warning from Dr. Peterson speaking on behalf of probably hundreds of people in her position, that with a census of 60% and staff where you can't get people, people are on the cusp of being eligible to have bad surveys, lousy, unsafe situations that are just nobody wants, inability to pay their bills. They're going to pay the bonuses before they pay the insurance on the building, and there's going to. I'm still really worried about this. So, and I know everybody on the call is. So, Senator Wickland, perhaps you can reassure us. Hello there.
Thank you, Mr. Chair. No, I definitely, I hear the concerns, and I hear that, we have a lot of work to do to understand whether the suggestions that are being offered in terms of attracting and retaining staff are going to help us. I guess at this point, I just wanted to say, I hope that if we have a broader discussion about, regulation and compliance and how that works on a day-to-day basis, that we also bring in some patient perspective as well. And I hope that the department could provide us more information about how our patients, expressing concerns, and are they getting resolved in these cases where there are concerns about care? Because ultimately, we want to have enough staff so that people are taken care of properly. We want the quality of care to be what it should be. So I hope we don't lose sight of that as well. It is a balance with compliance and, and regulation. And I understand that we don't want it to be onerous. On the other hand, I would like to hear more from a patient perspective on whether they're being impacted negatively, or we are actually maintaining a standard of care that is acceptable for these vulnerable people who deserve to be taken care of well. So I hope that if there are future discussions about this, that we can bring in more of that perspective. And then a question, are we going to talk about, I think I saw in a later presentation about vaccination. Are we going to have more discussion about vaccination and staff in nursing homes, or is that part of this this segment?
I think that's the end of it. So did you have a question you wanted to raise?
Yeah, I wanted to see if I could find out more information about how we're doing in terms of providing booster shots or additional shots to residents in the care facilities, and if we have any idea of the process that's in place to make sure that all facilities are accessing, booster shots for their residents. And I don't know whether
this is about workforce pretty much, but maybe Ms. Rydrick, do you just want to comment, and then maybe we can take that offline? And that's really, this is a workforce thing in particular, but Ms. Rydrick, do you want to comment just out of respect to the senator?
Mm-hmm. Yeah, Mr. Chair and Senator Wickland. And Senator Wickland, we did get your questions ahead of time, and so we can follow up with you offline today. And I don't know if Lisa's able to show the slide. For residents of skilled nursing facilities, we do get weekly data on that. And as of this Monday, 72% of eligible residents have gotten a booster, and that's 60% of all residents. So of those that are, at the time eligibility and medically eligible for a booster, 72% of them have gotten one. It is lower for staff. And we think that, slide 3, if you can show it, Lisa. We believe that the numbers for staff partly reflect some data issues because a number of staff get their boosters offsite. They just go to a clinic or a mass vaccination site or a pharmacy, and they end up not showing up quite as well in the facilities data. So I can follow up with you offline, though, Senator, on your other questions that you asked about the process.
Is that helpful, Senator Wickland?
Yeah, that helps. And I I think it is connected. I mean, the care of, patients and their families are concerned about the care they're receiving and whether their staff in the facilities are vaccinated, because that could affect their loved ones. And so I think that yes, I understand we're talking about workforce, but, certainly being able to maintain safety and care of the residents and making sure that they're understanding, how many of the staff are vaccinated. I think that has an effect on patients and their families. So that's why I wanted to bring it up today. Thank you.
Super. As we kind of wind this section down, Ms. Thurlow or Ms. Matson, do you want to offer any final thoughts? You've heard quite a bit of discussion. I think we need to figure out a way to deal with some information transfer, just some way to comment about some of these issues, just excited because of people's concern about, what might happen if they report something. But do you want to, either Ms. Matson, I want you to go
Senator,
first, or Ms.
Senator, could I just add a couple little things that I think maybe
please
help us? Okay.
Yeah.
So in our organization, we're really starting to look at the International Nurses Program, and how do we make a faster track through our Minnesota Board of Nursing and NCLEX world, and how do we do that? How do we look at the compact, the nurse compact for the state of Minnesota? And then it's the sustainable funding is just really how do we sustain as we go forward into the future? Because if this is what our world is going to look, where we have lesser residents and have enough staff to take care of them, then how do we fund that? And where do we put our priorities around really taking care of our elders? So that's all.
I appreciate that. Yeah. So if you can't get people for $10 more an hour, that's frightening to me. So I really appreciate you being here. Ms. Thurlow, do you want to offer a parting thought?
Mr. Chair, members of the committee, I'll be extremely brief. And first, thank you to you and members of the committee for your continued attention to this issue. I think the key takeaway here is that while the vaccine mandate is on hold, and that's bought us some more time, that we still face a very dire situation. We are very appreciative of the efforts and the ongoing partnership with the administration to look at both short-term and long-term solutions. And we're appreciative of the Senate for also being really creative and putting ideas on the table. I think we are at the stage where all ideas are worth looking at, and that we clearly need to continue to address these issues. As you've pointed out, there's not going to be a silver bullet here. It's going to be a sustained effort that requires permanent solutions. And we look forward to working with members of the legislature on a bipartisan basis to move forward to address permanent wage increases and other ways to expand the workforce pool to meet the needs of our seniors.
Thanks a lot. And Ms. Matson, you have anything else you want to say?
Mr. Chair and members, I do not necessarily, but we did have another provider that wanted to provide some insights. I don't know if you have time for that or not.
Well, if they could, I wasn't aware of that. So if, was that the regional vice president? Maybe if they could just, I would have brought them into the conversation soon. That's my error. So we're pushing our time, but maybe if you want to offer a minute or two, whoever that is, that would be great.
Thank you.
And now you've heard the conversation. So if you can fill in a gap that we haven't covered or emphasize something, that'd be awesome. So welcome to you.
Thank you so much, Chairperson.
Sorry to leave you out. It's my error. So welcome.
Thank you so much. It's a pleasure to be with you and address you and the committee members today. Real quickly,
what's your name, please?
My name is Mike Duth, and I am the senior or the regional executive director for the Good Samaritan Society for the states of Minnesota, Wisconsin, and Ohio. Specifically in Minnesota, we have 28 skilled nursing facilities, 31 assisted living, senior living sites across the state. Additionally, we have a variety of home health agencies and a hospice agency in the state. I am a proud Minnesotan. I live in the Brainerd area, lived here for over 22 years.
Yeah, cool.
And I would say, just summarizing what I had down, I could reiterate pretty much everything that others have said. Specific.
Yeah, don't do that. Give us something that we haven't heard that's kind of novel or just reemphasizes the point you think we need to emphasize.
You know, I would say that our costs for COVID-19 mitigation strategies, be it testing, PPE, that type of thing, we have spent over $3,600,000 on that in Minnesota, just Minnesota. Staffing levels, we really are focused on, we need staff to provide the care that we provide. And without staff, we're not able to provide the care that we provide. We've had to resort to outside staffing agencies to provide that care. I think this is an interesting statistic. Year to date, we had budgeted $690,000 in outside agency costs. We've spent $6,731,000 in outside agency costs for an 875% negative variance to budget. And that's for the year. For the month of November, we spent just shy of 1.5 million, and we have a negative variance to budget of 2,301%. So it's trending in the wrong direction.
You can't keep that up.
And it's simply not sustainable. It just is not.
Can you tell me what effect in your greater Minnesota places, if the answer is it doesn't matter, I would like to know that, but did you think that the CMS mandate has made it more difficult to keep staff and some have left? Or not?
You know, we have, as a corporate, we are a division of Sanford Health. And so we have 48,000 employees. We have had a mandate, and of the 48,000 employees, I think there's 433 people of 48,000 have not received an exemption or had the vaccination. And that's as of November 1st. Since November 1st, there's 100 employees, more than 100 employees that have received their second vaccination or their first, they're fully vaccinated. So we're down to a little over 300 employees.
Do you know how many have left rather than stay working in the nursing? That's what I'm really trying to get at here, because I don't know. It's hard to think, given the testimony that hasn't had some negative effect. And so as we try to resolve this in the future, it seems like it's something just to take into consideration.
I'm not sure that I have that number, but I'm not sure that it's been a significant, people have left, but I don't think it's a significant number.
All right. Sure. $1.5 million in
1 month. And then on top of that, for premium salaries for picking up extra shifts, year to date, we've spent just shy of $6 million on that, on a budget of $2,800,000. So you just start compounding all of the costs. It's been very challenging. I think the governor's interventions with the National Guard and requesting extra money, those are all appreciated and they're helpful, but unfortunately, those are just short-term solutions. And we really need to find a long-term solution. So I appreciate what you and your committee are working on here today.
Again, can you stick around a little bit? We're going to come up to the National Guard stuff later. So are you free to hang around?
Sure.
Okay, thanks. Well, I appreciate that. We just have to move along to the next topic. And I just want to announce that whatever we're on, we're going to incorporate MMB at 11:30 because they have to leave at noon, and hopefully we're done by then anyway. But so let's do the hospital thing, which is related. and so workforce effects on hospital bed availability. I'm sure it's the same conversation. And so just in the same order we've got listed here. So Ms. Rydrick and Mr. Pollock, do you want to comment about that? And then my plan was to go to, I guess, Ms. Krinke and Dr. Watson and then Ms. McHenry. So I don't know if anybody's in a rush. So maybe we want to get Dr. Watson off to this day. But if the department wants to comment, then we'll move to Dr. Watson, I think.
Mr. Chair, no additional comment from MDH right now.
All right. And Mr. Pollock, I bet you're going to say the same thing, my guessing, right?
Let's hear from Ms. Krinke, Mr. Chair.
Okay, let's hear from Dr. Watson then, and then we'll come back to the others. So Dr. Watson, thank you very much for joining us. I truly appreciate you doing that. Are you there?
I am here, Mr. Chairman. Thank you for having us.
Thanks. So we're trying to respect your time, and I don't, if you were listening to the first part, and how could you not? But it's, nothing is new that you heard. But anyway, thank you for coming, and the kind of questions we were asking. So welcome to the committee. Have you testified?
I have
in
not.
The Senate before?
Nope, this is the first
time. So there you go. This is something right
for the warm welcome.
Go in the Christmas letter.
And we appreciate
the
discussion on. We do appreciate the discussion on long-term care facilities. It is a backlog in getting patients out of the hospital, and is a real challenge in relationship to hospital space because of that. So I just have a few introductory comments, and I'm happy to take questions as well. So Mr. Chair and members, so first, my name is James Watson. I'm a neurologist and a leader in our outpatient practice, and I've been responsible for the operational part of our vaccine efforts across the Mayo enterprise, including Minnesota. As you know, we have worked with you in leading through the pandemic, both in test development, treatment development, as well as vaccine distribution, allocation, and trying to do so in an equitable fashion. We believe at the Mayo Clinic that vaccine is critical in managing the COVID-19 pandemic. We support vaccination as a safe, effective, and necessary tool in overcoming these stresses that we've been discussing, both in the long-term care facilities, but also in all of our healthcare systems and on our staff. We also recognize that vaccination is very personal and a challenging issue for some. We're here to discuss our commitment to pursuing full vaccination requirement for our staff. We've tried to lead this effort with an empathic and education-based process based on the best available science. We have taken an incremental approach to getting here. As some of our colleagues can talk about, who were a little bit ahead of us on this, but we began in the summer with a mandatory participation program. We allowed declination, including for philosophical reasons, provided that employees complete an educational module on that. What happened and how we moved then to a mandatory vaccine requirement is that we moved through this fall, and with widespread ongoing impact of the pandemic fueled by the new variants, threats of new variants, increasing numbers of infections, increasing hospitalization, increasing exposures to our staff, sick staff, quarantine staff, and by correlation then risk to their families, as well as additional accumulating evidence on both the safety and efficacy of the COVID-19 vaccine. It became clear that as we looked at our guiding principles in relationship to doing what provides the safest and the best care to our patients as the most important of our principles, that we needed to move towards a mandatory vaccine requirement. As we are doing this independent of both as our decision to decide to do this, as well as how we are proceeding, independent of the federal decision and requirement in relationship to requiring vaccine for those participating in Medicare or Medicaid. We recognize the applicable laws. Our current vaccine requirement does allow for exemptions for both medical and religious. We have established a thoughtful approach to this exemption process with large multidisciplinary centralized team reviewing these for consistency of effect. The process does provide for appeals, and again, does include a review process for assuring that the standards were applied evenly. The exemption process is ongoing. I know that you have specific questions in relationship to numbers. With the process ongoing, I don't have specific numbers in relationship to number of exemptions granted. What I can say is that the majority of those who have requested an exemption for medical or religious reasons have been granted an exemption. Some staff have received their written warning in relationship to being out of compliance. No staff have been terminated for non-compliance. Staff who don't receive a medical or religious exemption have until the beginning of next year, January 3rd, to maintain their employment here. So we want to retain all of our staff. We certainly appreciate and recognize the work, particularly through the challenges and uncertainty of the pandemic, by all of our staff. They've contributed tremendously. That being said, our highest obligation is to do everything in our power to keep our patients safe. We're a destination practice. We care for those patients who are acutely ill with complex medical needs. Those patients have the highest risk from COVID. Our cancer patients, our transplant patients, our immunosuppressed patients, and our patients with complex medical needs deserve and expect that we will provide the safest healthcare environment that we can. We believe that that requires moving to a full vaccination requirement for our staff to keep our patients safe. As other providers have experienced, and I'm sure will testify, we do recognize that there are workforce impacts from this mandate. As I said, we have had no terminations at this point, but we know that some will unfortunately come. We hope to minimize these with continuing outreach and education to them. We are prepared, however, to absorb the impacts of these vaccine requirements on staffing. We have had staffing shortages and fluctuations that predated the pandemic, and we expect will postdate the pandemic as well. And we've used tools to help us be successful through the pandemic to monitor staffing needs and nimbly adapt as far as shifting our resources to meet those patient needs. We'll continue to leverage these tools to bring flexibility and effectively supporting and utilizing our staff to best meet our patient needs. So again, thank you for the opportunity to testify, and I'll take questions when you want me to take them.
Yeah, and I think we'll do that now, and then I think we'll just maybe let you go do your day. I have a number of comments, but I want to make sure I'm fair to the rest and not monopolize this. So any questions from members for Dr. Watson? And if you think of one while I'm asking my questions, you can, but I'm just trying to be fair. And I told Mr. Hansen we would treat you kindly. So you're here as a messenger. You didn't set up the policy. I think you stated Mayo's position quite well, and I truly appreciate that. And this is not the committee where we're going to debate efficacy and all that. We're here about workforce. And I will express an opinion in a bit, but there was I don't know if you saw the packet, but there was a letter that came from somebody who did not want to be public, but it was just interesting. So I'll just express a few thoughts. I appreciate you have a committee, and this is for all the religious exemption people, in particular medical exemptions. I hope that those can be sorted out, and that should be just like if a doctor says you're going to die if you have this, or you have an anaphylactic risk for something, and even some of those are pretty short, 3 months. If you haven't had an anaphylactic reaction in 3 months, you're good to go. Like, really? Anyway, that's far beyond our scope here. It's just, to me, it just seems to be interesting. As I mentioned before, you heard me mention that America is a pluralistic religious country. We do have in the dollar, it says, in God we trust. Some people actually do not trust in God, and they don't have to. They trust in, another, whatever. And that's how people came here, was for the freedom to do that. And because I'm treating you well, I don't have to respond, but I'm just telling you these questions that I have. And I don't understand how any committee can judge my religious views to see if they're as good as yours or theirs. And I believe I heard that the number was maybe 70-30, you approve 70% and 30% are in limbo or something, which is better than none. But I don't know how, so there's just two concerns I want you just to please take back. And that's, I think, fair to you and to the Mayo. As I understand it, all I know is anecdotes from people who write me. Some of the denials that came in the appeal process was maybe 48 hours over a weekend, and some people were on vacation and didn't even see that, and the time has come and gone. If that's true, please give them time to appeal. I think if you read the letter that was submitted there, that's a really thoughtful person you wouldn't want to lose. And they said, can we please have a conversation? There was a couple who wrote me, I didn't write me, I saw the letter, and they were pretty much identical with their beliefs. One figure which one. One got the exemption, the other one didn't. Like, well, that's not even very scientific. So Mayo is like the North Star of, you know, America for healthcare. You've got so many things going for you in what you do. And then in this matter where on behalf of whatever, a couple hundred people, to tarnish that with some religious, you know, unfairness just doesn't seem like what you're about. I was reading about the history of Mayo, and I forget the name of the group, but there was a group of sisters that were allied with the original Dr. Mayo, and it was about faith and hope and medicine. And so I just hope that you can take this message back to your committee, and would you please look at all those ones you've declined and think, this does, I mean, I would have the question, do you have a religious belief that precludes you from joining us? And if they say yes, I'm in no position to judge that. And I think the people that are on the bubble here would find that to be really nice. That's my advice to Alina and to Essentia and to everybody, and to the Department of Health and everybody as they're looking at what people consider to be a religious concern. So was that okay? Do you want to comment about that, Dr. Watson? Or just please take the message back at least.
We will take the message back. What I will say on behalf of the process that was established is that it was a process that was not approached lightly. We recognize that this is hard. We recognize that this is a very charged item, and we recognize the impact of what these decisions are. We unfortunately feel that this is the right thing to do, and we cannot shy away from the hard thing to do.
Oh no, and I'm not interrupting. I don't mind that you want to do it. You get to do it. But I'm just talking about your process. That's what I'm pushing.
I think the process was thoughtfully evaluated with outside counsel in relationship to how to do this best and who were the best people to be those who would review and adjudicate these processes. The process was designed to be fair. It was defined to be unbiased. It was defined to have a centralized group that was reviewing these, so that the standards were applied evenly across, and to have an external resource review these to assure that the application of that was done evenly and fairly and equitably. As this went through, those multidisciplinary groups that reviewed had experts in relationship to employee rights, ethics, compliance, human resources, legal, and as we get into the medical ones, those pertinent practices to kind of adjudicating those, allergy, neurology, obstetrics, things of that nature. And the standards that we were looking for were basically sincerely held religious belief, and that those were consistently applied. Some of the situations where these things were not approved were things where things were cut and pasted in relationship from the internet, which kind of raised a question in relationship to the sincerity of that part of it. Or things were not a religious belief that were brought forward or expressed, but instead largely philosophical, political, or kind of secular in nature, or that they were a discussion of safety or efficacy issues as opposed to reasons for a religious exemption. Those are just some of the ones that have been shared in relationship to with employees in relationship to the decisions that were made here. The appeals process is ongoing, as I said. There are additional reviews currently of those people who have reached out because of extenuating circumstances around that appeal or around this, and we're reviewing those with appropriate diligence as well. So that is where we are. I hear everything that you say, and I will take those back as well.
Yeah, well, I appreciate that. I mean, just this letter came just like a day or two ago, and I said, "Can I use your name?" No. Can I post it? Yeah, sure. But it just, I don't think we're disagreeing. But I'm just saying you're not like, you know, some little place in, you know, some little island somewhere. I mean, you're a big place, and people look to you for leadership and trust and all that. So like this woman says, if anyone in HR actually talked to me, they'd quickly understand how sincere my religious beliefs are. So this was not a cut and paste. And so I'm just suggesting that if you could look at the appeals and just make sure you're treating people fairly. I am not here to defend somebody who cuts and pastes a thing that is a fraud. you know, I don't know how you judge that, and I guess I'm glad it's not me. That's my encouragement to you. So, and I know you'll take that back. I have one more thing I wanted to say, but first, any other members want to say anything? All right, so I just have another challenge for Mayo. So I want to love Mayo. I want to be proud of Mayo. I want to be voting for, no, I'm not pulling my vote out, but I want to be supporting everything cool you guys do. I want to just make you just be just amazing and serve the people you serve that we're so proud of. And in that way, I personally have some very real concerns about safety and informed consent. So this is we're not going to debate that for 1 second here. But I think it'd be cool if Mayo would on its own look into some of these VAERS reports, which are largely in many cases understudied, and just see what the truth is and have a real discussion about efficacy and safety. And if one is safer for a group of young men and one is safer for a group of young women, we should get to that point. And I think someone like Mayo could be the group to actually get at that. Not to be political, not to, you know, but simply the statement that they're safe and effective is a little simplistic, and I think you would agree to that. But I think that nobody in Minnesota is really investigating that on the VAERS reports. Are they real or not? You know, it's curious that 1/3 of those reports of death were in the first 3 days. At least that's kind of interesting to me. And so what if Mayo would undertake that and find the best way? So anyway, that's just a thought for you, and I hope I'm treating you well. I'm about to kick you loose so you can go back and solve some healthcare problems. So thank you very much. I appreciate that. So thanks, Doctor.
I appreciate
it.
Dr. Abler. Thank you.
You got homework assignment. All right, thanks a lot.
Thank you.
All right, Miss got my list screwed up here. Yeah, Miss McHenry, why don't you, I think we've covered things pretty well, but now you can, then we'll talk to Miss Frankie, who's going to take a different angle. So.
Okay, great. Did you want me to go, Mr.
No, let's hear from Alina just on that topic, and then we'll come back to you with the different concern.
Sure.
And I want to thank you for coming.
Yeah. Chair Abler and members of the committee, Kristen McHenry. I'm the Director of Government Relations for Alina Health. And I did have plenty of comments too on our capacity and bed issues as it
can you talk about that? I think we've covered everything else pretty well. And maybe you want to tell us that only 27 people are still in the bubble. Is that the number that you're at now?
No, why don't I, if I could, I'll take a minute to kind of run through the challenges that we're seeing, and then
go ahead. Yeah.
Happy to answer questions. So I think as everybody knows, our top priority is ensuring we're able to provide a safe, caring environment for our patients. And I want to start with gratitude. We have remarkable care teams who've been in the trenches of a pandemic for nearly 2 years, continuously demonstrating their commitment, ingenuity, and resilience in delivering a compassionate care in really difficult circumstances. So every day we have multiple coordination meetings in collaboration with other healthcare systems, and that helps us assess and optimize our care across our healthcare system to ensure that patients are getting the care they need. So as of last week, our remarkable care teams are caring for 28% of the state's COVID positive patients. Capacity fluctuates daily and remains tight across our facilities as well as across the state. Due to the extended surge of COVID-19 patients, high volumes of non-COVID medical needs worsened by delayed care from last year, seasonal illnesses like the flu, and then workforce shortages in many care team roles, as we've heard about. And then as we also heard about earlier, we are having shortages in skilled nursing facility beds for patients who need assistance from discharge. On top of all that, we're entering winter when we see additional pressures on our EMS system and EDs for weather-related injuries, and increased vehicle accidents. So it really isn't just one item. It's also a resource issue too, and our resources have been strained. Again, it's not just the result of one thing; it's a cumulative impact of the 2 years of the pandemic, bed, staff, and intermittent supply shortages. Again, as well as the shortage of skilled nursing facility beds for patients who need assistance after discharge. Just one example, and Senator Abler, this is Mercy Hospital in Coon Rapids last week had 41 people waiting in our emergency department for an inpatient bed, with 39 people waiting to discharge to a post-acute care setting. So beds are scarce, and that's just been the situation for an extended period of time. So we're certainly doing everything that we can to balance the healthcare needs of all the patients, including utilizing our in-home programs such as home hospital care that helps us manage hospital volumes. And then since September, we have been rescheduling procedures as safely as we can. So specific to the vaccine requirement, Alina implemented a COVID vaccine requirement for all of our employees earlier this year. It aligned with our long-standing best practices of employees having all of their immunizations, as well as a new policy requiring employees to get the influenza vaccine. We see this as an obligation to patients, community leaders, and most importantly, our own providers to lead on best practices. And so we have 99.8% compliance rate with our vaccine program, which includes medical and religious exemptions. So as we're in the thick of an extended fourth COVID surge and also responding to the news of Omicron variant, we believe that widespread vaccination efforts remain critical to suppressing the virus. I'll spare, specific to workforce shortages. This is, as mentioned, it's a long-term issue, and we really look forward to having this be a priority for public and private partnership. It's certainly a priority for Alina Health. And we know that we can't just do this alone. So it's going to take everybody to really train up the workforce. We're looking at every lever internally for recruitment and retention. And then I think food for thought as the legislature reconvenes in January, supporting these efforts by streamlining the duplicative background check process, extending temporary licenses, allocating funding for pipeline training, including reskilling, upskilling, and engaging youth, as well as loan forgiveness, are just some of the key things that I think we're working towards. So additionally, just want to put a plug into, we asked the legislator to support and pass a frontline worker pay program that includes all healthcare workers, whether it's the lab techs processing the results, the environmental services team ensuring sanitized spaces, or the team providing direct care to a patient. We totally support the state recognizing the full care team for their continuous hard work. So with that, I am happy to answer questions.
Thanks for coming. It's just better to have you in person than reading some memos. So I appreciate you accommodating my request there. Do you have, and so you told me a number. So I think you were down to 27 people or something. Is that right? That people that are not in the, whatever that 1% is, who are still on the bubble for not for in compliance. Yeah, that vaccine mandate thing.
So, yep, out of our 27,000 employees, we have parted way with 53 people.
53, all right. And so they have passed the time when there's no more, that was the grace period was done, so then 53, all right. And just given what time is and the conversation we had, I hope that if they put in a religious exemption, that they were truly considered. Cut and paste, I got no time for that. And given that we're needing all hands on deck, if there's any way you could look at those 53 and go like, well, maybe they were not so bad. That's my encouragement to you, as I did to the Mayo. Do you know offhand how many, is it a licensed bed versus a staff bed? Do you know where you're at in your world? Like how many beds, if you had like 10,000 more staff, how many beds could you open up? Do you know that?
I don't have that. I'm happy to follow up. I think, as I mentioned, it really is a both, and it depends on the day. Some days in one location we have the beds and not staff, and other locations we have staff and not the beds. So it just.
Yeah. Well, the reason I'm asking is some person named David Sims just wrote a letter, and he did some data. So according to back, and this is old news, but there was capacity and then staff. So I'm really interested in that. So it's not new data, but I try to respond to let people post what they want as comments from the public. So I'm really interested in that. And so maybe we'll have to take that up. But anyway, thank you very much. Any questions? Let's just continue on to Ms. Krinke, and then we'll go to questions.
Great.
Ms. Krinky, welcome to the committee.
Thank you. Thank you, Chair Abler and members of the committee. For the record, my name is Mary Krinky and I'm with the Minnesota Hospital Association. In March of 2020, when the pandemic first began, we started talking about hospital capacity. And hospital capacity was really measured by three things: beds and space, our equipment and supplies, and the third element was staffing. And in the beginning of the pandemic, it was all about the supplies. It was all about the number of ventilators we had and all about our personal protective equipment. And could we get enough PPE for our employees? As we fast forward now 20 months later, it's all about staffing, or more particularly the lack of staffing. I want to share some capacity information with you all that I have just received this week. And I think these are some of the numbers that Chair Abler had kind of requested that we look at. So this past week, hospitals were caring for about 7,223 patients in an inpatient acute bed. So they were getting care in the hospital in a bed, and we were at maximum capacity with that number. In July of 2020, that number was as high as 8,355. So unfortunately, this is a reduction of 1,132 fewer patients that we are taking care of on an inpatient basis. And this is not because there's a reduction in demand. It is because there's just not enough healthcare staff to care for the patients who want care or need care. Folks, to realize this is a 13.5% reduction in the number of available hospital beds for patients in just over a year. Hospitals have canceled, and I really appreciated Ms. McHenry mentioning this. Hospitals have canceled all procedures except for basically those that are life-saving or would cause extreme harm if the patient did not receive that procedure. Hospitals are basically just caring for very, very sick patients right now. And ICU beds are a subset of that number and are a very precious resource. Really, for the last 3 months, we've had very little ICU bed capacity availability across the state. The U.S. Bureau of Labor and Statistics recently published that 500,000 people have left their careers in healthcare since the pandemic began. Nearly 1 in 5 healthcare workers have quit their jobs since the pandemic began. And I think even more frightening for us is that when they interviewed all these healthcare workers across the country, 31% said that they had thought about leaving their current employer, or even more scary, the profession altogether. In its most recent biannual report, DEED, our Minnesota Employment and Economic Development Agency, cited that there were 30,000 unfilled healthcare positions in Minnesota. We are hearing from our members across the state that there are growing demands for obviously nursing, but also nursing assistants, laboratory professionals, respiratory therapists, rad techs, and dietary. So while we hear the most about the lack of nursing, it's really across the board in all professions. We will have more detailed information in a workforce report coming next year. Last week, we had a meeting of our human resources. These are the HR professionals from all the hospitals and health systems. And we had a discussion about workforce. And there are 3 takeaways from that meeting that I would like to quickly share. One of Minnesota's largest health systems in the state said that their overall applications had fallen by 50% compared to a year ago. So that's just so many fewer people who are interested in working in healthcare. The critical access hospitals in the meeting, these are the rural hospitals around the state, said that on average, they had vacancy rates of over 11%, and there just aren't people in the community to fill those jobs. Hospitals, and the third one I want to mention is hospitals reported that hiring RNs through staffing agencies and these temporary float pools has gone from a price cost of $85 an hour to over $200 to $220 an hour. Hospitals are under enormous financial pressure, canceling surgeries and increased volumes of Medicare and Medicaid patients, and we're paying a lot more for staff. We are very hopeful that lawmakers will be willing to use some of the surplus to help with not only short-term costs at hospitals, but as has been mentioned, longer-term healthcare career programs and workforce development, starting in our K through 12 education and in our colleges with loan forgiveness and other programs. In closing, I know I sound like a broken record because I have talked about this at least at 2 or 3 of Senator Abler's hearings, but we are continuing to be challenged by the criminal background check and fingerprinting process at the Department of Human Services. All the providers are going to have a new system in place that will begin on January 5th. And if you don't have your background check and fingerprint completed, you will not be able to start working. Even if you can find new people who want to come work in healthcare, they won't be able to start unless they get that background check and fingerprint done. We are hearing from some of our members, they're still not able to purchase the equipment, and we are fearful that the current backlog is just going to get worse, and we're worried about being able to hire new employees. So unfortunately, Mr. Chair, that problem remains. So I appreciate this hearing today, Mr. Chair, and all the efforts that you all can do to work on workforce moving forward. So.
Well, thanks. And Ms. Krinke, we were chatting. And you also remarked about if you want to buy your own equipment, you, according to the, I don't know who made up that part of the contract, but it has to be a legal citizen. And by the way, we're prohibited from asking if you're a legal citizen under federal employment law. So that just seems to be a horrible problem. And so we don't have any time to talk about fingerprints today, but I'm just going to tell DHS, we've talked about this for a long time. And the legislature, passed a law, Ms. Krinke, but that was in tandem with the department and what they needed and federal, all that stuff. So there's nothing fancy about the deadlines that we put in law. And so if it's hamstringing our work, and even if a doctor moves from a clinic to a hospital, they can't work at the hospital without a fingerprint test. That just seems like, just ridiculous to me and pointless in a world where we're, they're not going to become some, bad person overnight as they move from the clinic where they've served happily for 20 years. So just to DHS, we have to figure out a way around this. And it's just adding to the problem. So anyway, thank you. I'm gonna take questions when we come back. I told MMB we work with them, and I just have a small part for them. Let's talk about the data disposition. Ms. Bastian, are you there? I want to respect your time, and we just have this topic was that we've been working through workforce was obviously bigger than I thought when I was planning out the schedule. But are you there?
Yes, Chair Abler, I am here. Good morning.
Okay, well, thanks. And I wouldn't have thought much about this, but I ran across this article that somehow, I don't know why it even popped up, but in the LA Times that some sheriff out there, it's actually a relatively, I don't know, ironic or amusing or whatever, curious article. And so it provoked, and so their stuff's going to China with this company called Fulgent Genetics. And so the sheriff, who I don't know at all, who I presume is a pretty thoughtful person, is nervous to want to use that. And so I had asked the question when we talked about this some months ago, like the consent form that people sign when they get their testing done says you can do pretty much whatever you want with it for as long as you want. It's very open-ended. And so I figured that the protection was on your side where you've got an agreement. So can you just tell me, and you didn't know offhand at that time, which how could you? So now, can you tell us where we are at with our DNA security stuff? Hopefully that's a reasonable question to ask you. So welcome back.
Thank you, Chair Abler, members of the committee, Kristen Batson, Deputy Commissioner, MMB. Yes, we are prepared to answer. I believe the committee had 5 questions related to data practices around our testing program. Just some quick context. Under our COVID-19 proof of vaccination and testing policy, individuals who must work in person and are not fully vaccinated against COVID-19 must undergo COVID-19 testing weekly. As an employer, we're responsible to provide a safe and healthy workplace, and requiring regular COVID-19 testing for employees who have not been fully vaccinated against COVID-19 will mitigate risk to both our employees and the Minnesotans they serve. And additionally, the CDC continues to recommend the use of vaccinations to protect against COVID-19. The first question that you had is what is now specified in our current contracts with testing vendors for DNA management and security. And these contractors must comply with the Minnesota Government Data Practices Act and the Minnesota Health Records Act to the extent it applies with respect to all the data that's created, collected, received, stored, used, maintained, or disseminated by the contractors under these contracts. The civil remedies of Minnesota Statute 1308 apply to the release by contractors of the data that's governed by the Data Practices Act. And if a contractor receives a request to release data, they must immediately notify and consult with the state's authorized contract representative as to how the contractor should respond to the request. And also, per these contracts, the contractor's response to the request must comply with all applicable law. So just practically speaking, what this means is the data is not public and the vendor can only provide it to those with the legal authority to receive it. Now, the second question you had is what is happening to the testing data? And the answer to that is the access to private information that's gathered under Policy 1446 is limited to testing site staff, a designated testing laboratory, any designated vendor who will communicate the test results to the staff member and or the agency that they work for, the Minnesota Department of Health, any local public health department, state agency HR staff, the agency safety administrator, members of agency staff with a business need to know, and any others authorized by law. The two primary methods of weekly testing for our employees are either at a metro testing site that is staffed by Homeland Health, or two, vault testing that is done either at the employee's home or at their work site. For the metro testing clinic, the vendor has explained to us that negative samples are destroyed by incineration once the test is reported. The lab holds onto positives that are frozen down, as these can be helpful in testing validation. But as soon as the lab stops doing COVID testing and sequencing, those samples will be incinerated too. Homeland Health specialist at the metro testing site receives the information in the specimen as they perform the sample collection, and they follow up with the patient to explain the results. Primary Diagnostics Incorporation receives their information to run the testing enrollment, the sample requisition, and return results to the patient and their agency digitally. And then Mayo Clinic Labs and or the University of Minnesota Genomics Center, receive information and specimens to process and communicate test results to the Homeland Health specialist. If the test result is positive for COVID-19, then their information and the positive test result will be reported to Minnesota Department of Health and or local public health department for purposes of contact tracing. Public health department officials at the Minnesota Department of Health, the local public health department, Mayo Clinic Labs, University of Minnesota Genomics Center, and Homeland Health specialists may also use de-identified specimens and other de-identified information to conduct community-level disease analysis. For the vault testing that is done either in the employee's home or on the work site, for those using that testing and their employer has HIPAA consent, the results are shared with the employer. Otherwise, they are just sent directly to the patient. And positive samples are sequenced by the lab and the information is shared with the CDC. Samples are retained only for the performance of the test and the associated quality control purposes that go along with that. And then the sample is promptly destroyed thereafter. And samples are not held on to longer than 2 weeks. The third question that you had was about the chain of custody of test samples. And first of all, M&B employees are not involved in the collection, transportation.
I think you've persuaded me that you've got a good plan in place. So, so I mean, those are, I'm happy it went from, I'm not sure, to like, it's under Minnesota Health. When you got me at Minnesota Health Records Act, which I really like. I'm glad we don't have the broader version, frankly, that maybe you wanted, but so thank you for that.
You're welcome.
Trying to truncate the hearing a little bit. So I think we're going to skip number 3 altogether, but I have a couple of questions for you on our favorite topic together, which if you don't know the answers, you can let me know. And it seems like things have moved a long ways, but I've still gotten concerns about privacy and testing with people at the workplace. And so I know you don't intend that, but everybody knows everybody who's getting tested pretty much everywhere, which I don't think was part of your plan. So there's a gap there, which I got a letter recently, a week ago, where people are still testing and everybody knows. So if you can put a note about that and just find some way to put the genie back in the bottle and protect people's right to privacy, that would be great. I'll leave that as a comment. A guy wrote me who had a positive test one day, and the next day, and so he had to take off time. And then he had a negative test the next day. And so he still had to take off work for the whole time. And can you ask somebody if that's what they meant? It seems like if the test means, I mean, there's false positives and false negatives. And I don't imagine you know offhand that question, but can you take that back to your home office and see if you have a negative test, it seems like that's the whole point of the test. And actually the person that had the quick test, then he went to his doctor and had the better test. And the better test, which was whatever that one was negative. So I don't know why that shouldn't hold up and let this person go back to work. And so if you want me to give him your name later, I can do that. But has that ever come up in your mind, in your understanding?
Chair Abler, that has not come to my attention, and
Yeah.
I would be happy to look into it, but I think we would have to take each case like that on a very individual basis and look into the specific facts.
But I mean, this guy just, I mean, these people mean well, they're testing, they're doing their thing. And then just on that same matter, are you still doing that if you're vaccinated and you get COVID, you get 7 days off, and if you're not vaccinated, you don't get 7 days of paid time? Is that policy still in place? Do you know?
Yes, it is.
All right. I still think that's unfair. And then with the breakthrough cases, there's considerable numbers of those. Some say, 20, some see. I just read in the paper that 42% of the breakthrough cases in some hospital in America were vaccinated people. Have you considered broadening the testing out to people that are symptomatic that have been vaccinated, or some way to start to deal with these breakthrough cases? And you're really going to test to really test.
We're watching the data very closely.
You don't have to, if you have a lot of that, I think you take it back to people.
We'll certainly do that.
You're kind of freezing out there, but it seems like it. I mean, the governor is pretty much a fan of testing, and so even in fairness to the state employees who are vaccinated or who are not, and if they got some person wheezing next to them, it seems like they're fine because they're vaccinated. So I appreciate that. So, any questions from members from Ms. Bastian? I think you got off pretty easy today. Were we nice to you? So you got some homework. So just please, people. My whole point of all this testing is treat people fair, and and respect their views, which I think we're working that way. So I don't see any hands. So thanks, Ms. Baston. I really appreciate that.
Thank you.
Yeah, and hey, by the way, congratulate your commissioner on another surplus. We pretty much attribute all these surpluses to the capacity, to the skill of the commissioner, MMB commissioner. So.
I'll certainly pass that along. Thank you.
Thanks a lot. Very nice. All righty. So I think let's just go back to the hospital bed availability a bit. Any questions from members about that? I don't see any hands. So we're just gonna, for now, we're gonna skip number 3. The reason I asked that question is a facility in Anoka closed, CARE it's called, and it was a substance abuse place, and they couldn't find staff. And when I proffered the question about has some of the mandates that we've been having around here affected your capacity to find staff now that we're closing programs, which I fear more will close. Well, I asked the question, well, what's the effect of people with the, the testing frustrations and the other ones, other mandates? They didn't know. So I just think it's something to consider as we're trying to recruit staff, particularly on the religious exemption. If you haven't picked up a theme from me, you should treat people fairly. So let's, and thanks to Ms. Bastin. So let's go on to number 5, the National Guard. And who's talking about that? Ms. Rydrick, welcome back. So good to have you here so much. And so you can look at the clock and see the time's moving along. So I just briefly, if you can reply to those between you and Mr. Pollack. There's no trick questions here. I'm just curious. You were training what 400 to go into work by the 5th, and I'm just curious how many are there now and kind of how's it going. So thanks.
Yeah, Mr. Chair and members, if Lisa Timian is able to pull up slide 4 in the deck that I sent her, that'll be helpful. But yeah, so as you know from the announcement that went out about the National Guard, the initial deployment or the initial activation of the Guard was 400 individuals, and 300 of them have completed their CNA training. 100 completed TNA or temporary nursing assistant training as of the end of last week. And just before Thanksgiving, we opened up a process to get applications from skilled nursing facilities for a National Guard response team. And this is data from yesterday. So as of the end of the day yesterday, we had gotten 42 requests from nursing homes. The map on the left-hand side just shows you the counties where those facilities are from. So you can see definitely a path through, in particular, central Minnesota into northwest Minnesota, and a number in the metro area as well. The way that the process works, we review those applications, we talk to the facilities, we have case managers who talk to them about the situation they're having and the number of shifts that are unfilled and whether they're in COVID outbreak. There are a number that do have outbreaks right now, and we are not sending the National Guard into any facilities that have an active outbreak. So through that process, we are filtering down to the ones that are in most critical need right now, and those are the first ones that get referred to the National Guard for a site visit. So the map on the right shows I think it's 15 as of yesterday that had been teed up to a National Guard team to go out and do that pre-visit with them. And
so a team is 15 people?
Mr. Chair, the size of the team varies. So the first 3 teams that were announced yesterday were 30, 10, and 10. Okay. North area had 30. I would say the average size seems to be 10. So we announced the first 3 teams yesterday, I think, or on Monday. We envision having at least 9 teams deployed to nursing homes by the end of this week. And each day we meet with the Guard and we review their site visit notes.
So like 150 people, 150 Guard or so.
I believe the number that are around right now in the facilities that have started is 81. And by the end of the week, it'll be over 100. But again, we add new sites each day.
Cool.
So if it is helpful at all, the next slide does give you a sense of how severe the staffing crises are in these facilities. We modeled a survey that we did with the long-term care associations a couple months ago, and we asked them just kind of rating their crisis, red, orange, yellow, green. And so you can see the highest number of the applicants are in that red category, and those are the ones that we're triaging first to the National Guard, the ones that are in most severe crisis, and then we're moving through the.
All right, you're going to depress us if you stay on that slide too long. We've already talked about it today, and we're all sad, and we got our hands full, don't we? So you can keep going.
Yep. So I think you had asked a couple of questions, Mr. Chair, about the nature of the National Report, which I can just quickly walk through. They go out to each site for a minimum of 2 weeks, and then we work with the site and the Guard at a midpoint to decide whether they will get a 3rd week. 3rd week is the maximum. They are trained as CNAs and TNAs, but we also ask the facilities how many vacant shifts they have for dietary and housekeeping and ancillary roles that a CNA or TNA might be able to do. And so some of the Guard members would be providing those non-direct care supports at the facility as well as dietary or housekeeping assistance based on the needs of the facility.
Sure. And then I asked you about what's going to happen after 3 weeks.
Yeah, Mr. Chair, you did. And so at this point, we can't say what the outcome is for these facilities because the National Guard only just started being on site within the last few days. We're working through that process with facilities and with the Guard. I think for some of them, this creates a softer landing. They may be pretty far down a path and they may already be considering closure. That is something that we ask them about. Most are saying no, but there are a couple in there that said it is something that they are contemplating, and this might give them a little bit of breathe about that. For others, we ask them what's taking while they have the team there, while they've got this breathing room, what additional steps are they going to take, or what resources are they going to seek out in order to help them address some of their staffing concerns going forward. So we'll work with them to help them understand what financial and other supports that are out there for them as they consider their options.
Very good. I think that's enough on that. Do members have questions? I think it's a good stopgap, at least it buys some time. And, back to the first question I asked you, Ms. Rydrick, how many are at risk of closing and so on. I think this chart probably gives you a pretty good hint about just the fragility anyway. And I just, and I don't mean to overdo it, but I just can't help think it's aggravated by some of these requirements that have come along with mandates and people's frustration with rolling out testing, and well-intended. And I'm not trying to go very far down that road, but I'm just still very worried how people are going to wind up on the front steps somewhere. Any questions from members? Oh, I can't find my list. Here it is. So anyway, and just to kind of wrap up today here, the governor proposed $50 million, which I think is a good idea. I didn't ask any of the providers. So on the average, you're going to get like the plates are in your handouts. We don't have time to go through those, but pretty much I think Mr. Pollock, wasn't it a range of 3,000 to 120,000 with an average of about 60,000 per place?
Thank you, Mr. Chair. Yeah, there's some more detail in the slides that are posted on the committee website. On the sort of per employee basis, it really depends on their Medicaid participation. Right. And there's going to be flexibility for facilities to decide how much of an incentive to pay, but it's generally about $1,000 to $4,000 per employee. The median is $1,095 is kind of what we're estimating.
Yeah, I appreciate that, and the effort. Dr. Peterson, are you still around? If you had left, I don't blame you.
Mr. Chair, my apologies. Dr. Peterson had to leave, but I'm happy to take a question back to her.
Yeah, well, I'm just, I mean, these tens of millions of dollars add up quickly. And so I favor the governor doing what he did. And I think it actually could be even more just to fill the gap, even as a crisis. But is that average number 50, 60,000 times however many sites, is that going to make a significant difference, or is it just going to stave off the inevitable? Or can you comment about that? I'm not trying to pick a fight with the governor and you all, but I'm just, it's amazing how quickly you spend $50 million and have a modest impact, which is what I think it's going to be. Ms. Thurlow.
Mr. Chair, members of the committee, thanks for the question. I think first and foremost, I think we're very grateful that the governor has made the step to release $50 million to provide these grants. I think we recognize them for what they are. They buy us more time. They are temporary, they are bonus payments. And we know that our hope is that it helps us stem the tide or reverse the trend of losing employees in our setting so that we can keep them. But we also know that we have more work to do. I think everybody around the table recognizes that there's a broader conversation about permanent solutions to not only provide permanent stabilization of the sector, but also expand the pool of available workers. So we're very grateful to get us through this holiday season, but know that more needs to be done.
Sure.
Mr. Chair.
Anyway, so yeah, Mr. Pollock.
Well, just to Ms. Thurlow's point, I mean, I think one of the things that we're buying time for are the interventions like the one that the Office of Higher Education announced this week, which was to put out, ARPA funding for training and pathways for 1,000 new CNAs by the end of January. So there's some other things that we're working on as well.
And I appreciate that. And actually, it's, do I have it here? Oh, good. So yeah, and to that point, I appreciate that. And I try not to be too cynical, but here we've got, you heard in Zumbrota, they're giving people $10 an hour more, which is probably the old pay base from 3 years ago, $10, moved up a little bit. So maybe they're getting low 20s or something, $25 an hour. Do you have any idea how they're going to recruit to 1,000 CNA enthusiasts who want to go be one of those? And that, maybe it's just a moot question, but I hope you can find the 1,000 people and more, when they haven't been, they'll find them elsewhere in the hiring process.
Well, actually, Commissioner Olson would be better situated to speak to that if you decide to have a 7th hearing, but they're kind of doing all of the above approach, and who in the community, who in a high school or college just needs a pathway to becoming a CNA, and it's a great kind of teach a man to fish approach.
Sure. And I do have a question for you, and today it's posted. This is today's St. Paul paper, talking about the governor's ideas. Talk about loosening some rules for emergency staff and providing incentives for workers to stay on the job and for new hires. Do you know anything about, I'm not aware of any specifics. It came up in today's paper. Are you aware of some program that for retention and new hires? Was that just the $50 million thing, do you think?
I'm not familiar with which article you're referring to, Mr. Chair, but the goal of the 50 million is to do both new hiring and retention incentives for current workforce.
All right.
And again, the slides do kind of show you get a nice distribution, particularly in slide 3, some of the rural counties on a per sort of healthcare nursing home worker basis.
I'm not trying to make you not talk. Do you want to?
Oh, okay. I wasn't sure if you had time, but yeah, I can.
But it's important. I don't want to be unfair to you.
Yeah, I'll just show this one. I think this is a really nice one to just give a sense. Obviously we've mapped a lot of this data. We know kind of where the Medicaid bed distribution is, and this gives you a sense, of kind of where the top 25 counties are. Just again, these are average incentive payment per nursing home worker in that county. Aiken, Beltrami, Medina. It's going to go to some of these counties that we know are having the hardest time.
No, I appreciate that, and just to kind of. And so, 4 of us in the last, not to get this wrapped up in other topics, but 4 of us on the committee and around our caucus sat down and put some real thought into some emergency things that would make some sense to try to make a difference. And I think at some point, it'd be good for the governor to work with us on some of this stuff. He was pretty cool to the whole idea and even implied that it wasn't even that good of an idea. And I worked with the long-term care people on some of these things. And so particularly, we're in a world of hurt, Mr. Pollock, and you know that. And, dueling proposals aren't always productive, but at the end, we've got to land on something that's going to keep the system intact. And if anybody watching this hearing for the first time doesn't think that there's something where you start having one company with $1.5 million in bonus and excess payments in 1 month on a budget of $2 million in a year, that will not last. And so I just wanted to mention just a couple of these things, and none of them are rocket science, but we have to find a way to draw people in, and I appreciate the governor trying that, and we need some more ways to draw people in, and and apparently it takes a good amount of money to get them to even walk in your door. And this was about a $200 million proposal, using the legislative money that was set aside from the federal. So we were taking our money, by the way, not just your money, Mr. Paul. Anyway, and so in there we mentioned the nursing home citations as an issue, but there's something else that we talk about waiving some other fees, and there's energy assistance. But there's something I wanted to raise up out of those, of all the ones that might make sense, and that's what I call the emergency voluntary receiverships. And they wouldn't have to be a receivership, but they could be a quasi flexibility time. And you're actually, it's probably Ms. Tingen's department, or Ms. Rydrick's department, both theirs. But I think there is a lot of crisis, and we heard that people are nervous to even tell the agency that they're in trouble because of past issues with the rapport between the surveyors and so on. And so this one senator from Western Minnesota said he had one place closing, another one's about to, and the third's on the ropes. And I'm just surprised at the disconnect between that and the state not even knowing that, which I'm not here to criticize them, but there's more trouble out there than anybody knows. And I think we could listen to Ms. Thurlow and Dr. Peterson and Ms. Matson and others. It doesn't take rocket science to figure that out. So I think even administratively, we should, that could be done somehow, probably in a way just to kind of say, okay, you're in a, let's call it let's send one National Guard guy out there as a team. Now they're exempt from some of the surveys, and we can work with you, or find a way to work with people and to keep them open, because they're not going to reopen once they close. And especially in, the money that is put out there, $1,500 a person, is going to help stave off the time, but it's bodies on money. So anyway, so I hope you realize, and I believe my committee is bipartisan enough to make you know that we are here ready and willing to work with the governor and your department to get after this. But I just have to say, I feel like I kind of I don't get lonely, but it's, I talk to you and Commissioner Harpstead sometimes, and but there could be a much stronger connection to the legislature in putting some of this forward that actually will be productive, because it's going to take some money. And unfortunately, the governor's had this big buckets of money. Here comes a $3.5 million to find 1,000 CNAs that hopefully will materialize, and doesn't require any action from us. And so I think it's time to get back to standard operating procedures and engage us as we talk about these ideas and others. And so, Ms. Rydrick, are you still there?
I am still here, Mr. Chair.
Oh, thanks. Is there some way that we can, this emergency voluntary, whatever you're going to call it thing, do you have enough administrative authority to work with a nursing home and help them to soft land themselves and avoid closing, if they would just tell you that they wish they could have some of the receivership benefits, where there's, some things are kind of waived for a while and stay open? Is that possible, or,
Well, Mr. Chair, I would just clarify, a receivership doesn't grant regulatory relief to a facility. Again, our responsibility is to keep residents safe, and the facility, the managing agent who's managing a facility in receivership during this, they still have to follow all regulatory requirements to keep those residents safe. So it is not a free pass for them. It is not a relief from regulatory requirements around resident safety and resident.
Are things more focused, or I just heard it was, I guess I'm ignorant on that. Sorry. So it's the regulatory work is not more focused on kind of essential matters and the safety matters. It's the same full boat thing.
So, Mr. Chair, we already, just because of the pandemic, we are prioritizing the survey work that we do, and we are prioritizing our work around serious complaints and not the really minor complaints. And so that would apply to a facility that's in receivership or to any other facility. I just don't want there to be an impression that a receivership is something that a facility should want, or that it grants relief, because it does not. But if a facility is struggling, they can reach out to us. They can reach out to DHS if there are options around consolidation, if they want to move their residents to another location, consolidate where their staff are. That's something we could talk to them about. We can help them understand what the requirements are and what the options are and what the pathways are for them. But I would not mix that with the concept of receivership, because
I appreciate that.
I don't think anyone would volunteer for.
Yeah, no, actually the idea came from someone from the long-term care side. We're wrapping up now, but it just seems to me that there has to be some way where the Western Minnesota place that's going to close that you don't know about, it's going to be on the list pretty soon. I don't even know where it is. And that's a pretty broad area, so I'm not getting them in trouble. But so there aren't a lot of places to go out there. And once you lose one of those places, it's never going to be replaced. And it's probably a major employer of 100 people or more in its town. And the ripple effect of all that, from the people having to drive 40 miles or 80 miles to see their loved one, much less now, is just totally undesirable. So maybe offline or something, if the imperative people or you all have some way to try to decide, we don't want any place to close. And the National Guard is a way to kind of stave that off for 3 weeks. But I don't know what else there might be, but I don't think we've been in the position we've been in ever, where so many places are so rickety in their operations. Economically, where they're going to wind up being either closing or in some kind of supervisory receivership like situation. So anyway, maybe take that back home and we can talk some more internally. But anyway, thoughts from members as we kind of come in for a landing here. All right. Well, I think it's been a good hearing. I guess I'm glad things are as stable as they are. But I'll just speak for me and the people I hang around with. I think as a committee, we're committed to helping this go better. And so actually the takeaway on this, if you're a group in a nursing home in trouble, don't be afraid to call for help, because it's not going to come bad on you. And if it does, make sure you tell me or one of your senators, and it seems that Department of Health and DHS are sincerely interested in helping you get through this time. And anybody who's sick with any disease needs to ask for help. And so then otherwise they're not going to get the help they need. And so, your condition is not a disease, but it's a real challenge at caring for how many people are in nursing homes these days. Lots. We need that available. So anyway, with that, thank you for all your time and attention. Merry Christmas and all that to everybody. And so with that, we're adjourned. Thank you very much.